There is a type of difficulty that exists uniquely in America. Dr. Alice Feller, MD, writes about it in her new book, American Madness: Fighting for Patients in a Broken Mental Health System. Dr. Alice Feller has written a clinical memoir that brings the reader into the world of serious mental illness using patient vignettes and personal accounts of her work drawn from medical school, hospital wards, private practice, public clinics, and beyond, spanning a career from the 1970s to the present. I found this book quite compelling. There are chapters devoted to treatment outcomes, homelessness, substance use, racism, family involvement, and early intervention for schizophrenia. Dr. Feller identifies specific barriers to care and advocates for reparative strategies that would make the most meaningful and immediate improvements. This book is meant for anyone whose life is touched by mental illness, whether as a patient, a family, professional, and it is a must-read for policymakers in the field. Dr. Alice Feller is an MD. She's a doctor, a clinical psychiatrist, and a writer. She has worked in private practice, emergency rooms, psychiatric wards, chemical dependency programs, and public clinics in East Oakland and beyond. Her writing, focused on mental health, addiction, and homelessness, has appeared in the East Bay Express, the Laney Tower, Cal Matters, Fort Da, and Incoming Circles, as well as the opinion pages of the San Francisco Chronicle and the New York Times. She has served 2 terms on the City of Berkeley's Homelessness Commission and is an analyst member of the San Francisco Center of Psychoanalysis. I think you are going to love this interview. She is full of passion and she has tips for you if you want help and also how to get involved. All right, let's get to the interview. Welcome, Dr. Alice Feller, to the Intentional Clinician podcast. So great to have you on today.
Thank you. I'm really pleased to be here.
Excellent. Yes. So I've been reading your new book, American Madness: Fighting for Patients in a Broken Mental Health System. And in this book, you are illustrating so many points of view from, it's sort of like a memoir in a clinical way. Of working in hospital, wards, private practice, public clinics, private clinics, going from all the way from the 1970s to basically present day. And then you do talk about other impacts, homelessness, substance abuse, racism, family involvement, things like that in the book as well. So I thought this was, so far from what I've been reading, an excellent book and really gets into the nitty-gritty details that I think not only should families know about, but also professionals and policymakers that are involved in the field. And I think there's obviously a big push for advocacy to fix the mental health care system in here. Yeah. So yeah, I've been enjoying it, but I wanted to hear from you. What are some of the reasons that you decided to write this book?
Okay. So I'm a writer. I mean, I write just for myself and for my friends. And when I first started working at these clinics across the Bay, these public clinics in the last few years, I was so outraged by what I saw, the deterioration of our system and how badly it works now. And I'd go home and just write things that moved me, a patient that was heartwarming, but I'd also write about the failings. I can talk about those more if you want, but, and I like to write. And so I started, it sort of gradually happened that it turned into a book.
Oh, excellent. Okay. So just kind of reflecting on your own experiences, because there's experiences in here with insurance companies and medical staff and behavioral staff, but a lot of patient stories and patient family stories, which I thought were really interesting. So just sort of putting it out there and obviously fighting for patients in a broken system. And that's kind of how I feel a lot of clinicians feel these days. I've seen it just get worse since I got started. I got started in 2007 working in Illinois, and they have closed down most of the clinics that we were working in the community mental health. That was after they closed down the mental hospitals, which you go into detail about in the book. And instead of patients getting the long-term care they need, they are either usually in and out of hospitals, living in the streets, and nowadays in prisons and private prisons, where the taxpayers are actually, I think, in my opinion, paying way more than they would have for clinical care in the community when you have to house somebody for years on end and feed them. Yes. Thoughts on that?
Yes.
Any thoughts?
Oh yeah. I mean, I totally agree. I hadn't thought about private prisons, but absolutely, it's a huge waste of money, what we do. I mean, aside from being totally inhumane and impractical.
Yeah, it seems like not only is it a waste of money, but it's a waste of money with a purpose. The purpose is to preserve a myth in our society that there are good people and bad people, and bad people make bad choices and they end up in bad places, and that's prison, right? And that's just such a childish, toddler, immature way of looking at the world. And it's a lot more nuanced than that. And yes, there are people that make bad choices and do end up in jail, but there's a lot of people that are mentally ill, especially with severe mental illness, which you talk about in here, that are not getting any care, almost any care at all, and are, causing self-harm, but also harm to others in the community, and usually do end up in prison at some point. And so we could go into that, but I do think that I just wanted to point out that it is preserving a myth that our courts and a lot of people in the culture still believe to be a true thing, because the nuanced view is not there. Yeah. So let's start at the beginning.
Okay.
You grew up in a home where it was not a very safe place to be with your father's mental illness. Could you touch on that a little bit?
So he got worse and worse as time went on, but when we were children, he would explode and sometimes be violent. He wouldn't be violent against us, but he'd throw things and break things and just be very scary. So when I was in high school, I wrote a term paper on schizophrenia because I thought maybe he had schizophrenia, and if he did, he could be treated. He didn't. I found out as soon as I got into the paper that he didn't have schizophrenia, but probably some sort of mood disorder. I don't know. It's hard to diagnose your own parents.
Yes, it is. Very difficult. And and so you went into, you were dealing with that as you were growing up. And I was curious, did that influence anything in terms of you becoming a doctor and all of that? Or was that just sort of something you were into?
Well, I went through a lot of changes between that time and high school. But of course, yes. I mean, it affected our whole family. His situation, his illness affected our whole family. The whole family became ill in a certain way. It's hard not to react to it. We'd get our friends out before he came home. We knew that we were weird, and we didn't want. That was embarrassing and shameful, and we wanted to look as normal as we could. So that affects you if you grow up like that.
Yeah,
you feel like a weird person from a weird family, and that sets you apart. So in some ways, I felt at home in psychiatry. I mean, I liked it. I enjoyed it. But I also felt like these are my people, and I like them.
Yeah, so just
mostly.
Well, right. And you were talking about in medical school how you just decided one day, you were like, I think I can do my own path. I don't just need to go and do internal medicine like all of my peers or specialize.
Exactly.
This is interesting to me. And I think if you had gone through something as a child where you felt like, oh my gosh, this like difficult thing and this secret we have to keep, it might have influenced you somewhat to be open to people that are maybe not in the norm of, mainstream society. I'm not sure if I'm hitting.
Oh, yeah, definitely. It's well put.
Yeah. Well, I'm glad you did, because you had you helped a lot of people, and you could see that throughout the book. You were sticking to your ethics, which is tough to do in a system that's so screwed up. But I guess it wasn't even close to how screwed up as it is now. Even in the 70s, it wasn't great, but you had more resources, it seems. So you were in community mental health. I want to educate people about community mental health. So there was an act that happened, and I don't remember the year, so you're going to have to help me with this. But at some point, we had a lot of mental hospitals in the United States. And the government passed a law that said Medicaid and Medicare dollars cannot go towards treatment of mental health over 14 or 16 days, was it?
In an IMD?
Hospital. Yes, I'm sorry, in an IMD. Yeah, so you can explain what that is?
Yeah. So an IMD is the initials for an Institute for Mental Disease.
Yes. Okay.
So a psychiatric hospital, or even an inpatient drug and alcohol treatment program.
And so in that situation, they were, I guess, were they trying to save money? Were they trying to empty out the hospitals? Because there was like that whole push, and I read this in a different book about how hospitals were supposedly inhumane and like ruining everything, and how they had to like get patients back into the community and not in a hospital, which seemed to be based on anecdotal evidence. I mean, there were definitely some abuses in hospitals, but there's abuses anywhere. So it sounds like the government was pushing that because all of these, not all of them, but most mental hospitals started shutting in the way we knew them, especially using any sort of public money, were shutting down because they didn't want to lose funding. Is that what I'm hearing? Or they wanted to go with something less risky?
I think that the patient's rights, all that sort of outrage about putting people in a hospital against their will and treating them against their will, which isn't nearly as true as it sounds. I think that gave cover for Reagan. And I mean, he was the first in California. We had the hospitals shut down first, and there was a big movement that was supposedly very righteous in the 60s and people didn't have any idea what serious mental illness was. And the fact that people don't know that they're sick and they're not going to go into some volunteer situation. They just won't.
Right. And so we have usually some of the diagnoses for severe mental illness would be bipolar 1, which has severe mania and severe depression, all types of schizophrenia, schizoaffective disorder.
Right.
I would say major depression, severe with psychotic features.
Yes.
Sometimes some obsessive compulsive disorder treatments can get so bad that people don't leave the house and eat. What some other ones do you encountered in the severe category? I mean, substance use, obviously. But.
Right. I think that covers it.
Okay, those are the big ones.
Yeah, definitely.
And anecdotally, clinicians always say when somebody had, or substance use disorder, so like severe alcohol disorder, severe cannabis disorder, methamphetamines, anything like that. And people say when people get these severe disorders, the anecdotal thing clinicians used to say is when somebody has bipolar 1 or schizophrenia, they don't tell you, their family tells you.
Yes.
Their family brings them, that the community is concerned because the person doesn't always know that something is wrong. Can you explain that to the people?
Oh, sure. Well, in schizophrenia particularly, people don't know that they're sick. And as time goes on, they're less and less aware that they're sick as the disease gets hold of them. I think that's true in the bad end of a manic depressive phase, in a manic phase. People are grandiose and think that this is true. They're not aware of being sick. I think people who are severely depressed are pretty aware that there's something wrong.
Yeah.
In my experience.
Yeah. So people with severe depression will tell you. I think that, so in community mental health, a lot of what we're doing with severe mental illness is we're trying to help the person become safe. And so oftentimes they're a threat to themselves, often due to either suicidal thoughts or sometimes just not taking care of themselves, not eating and not going into shelter and maybe, walking down the middle of the street or something like that. Is that what you were seeing?
Yes, definitely. All those things.
So the hospitals closed down. I mean, the idea of community mental health in concept sounds good, right? We have these community mental health centers and many of them in big cities. And then in every medium-sized town, we have a couple of these, and public dollars help fund these things so that people can get the treatment they need, and families can then help the person become rehabilitated. And thus there's less of a threat to that person. And then occasionally, not that people can be threats towards others in these situations as well. But it seems like there were factors limiting your ability to treat. Because at one of the places you worked at, it sounded like it was great. Like you could have them in the hospital and then bring all this family treatment in. Yeah. And that was the ideal community mental health center. Can you tell me about that ideal center not ideal, but pretty ideal for the time? Can you explain that?
It was, sure. It was extraordinarily ideal. I didn't know that. That was where I did the first half of my residency. Mm-hmm. So 2 years, and it was run by the county of San Mateo County, which is fairly wealthy and not that populous. Right. So they had the money to do this, but they also did it right. I mean, they didn't sell it out to some private entity. So we had a small hospital with room for. We never seemed to run out of room. Actually, we worried, we're on the edge of it, maybe 1 or 2 beds left, and you don't want to casually admit someone who's maybe kind of borderline. But it was extraordinarily better than what we have now. And right. It was, the other thing about it is that people and the system, it was one system run by the county. And so everyone was on talking terms with everyone else, which is incredibly important. Okay. Today, what we have is it's isolation. People outside your immediate space are off limits. You don't talk to them.
I see. Right. And so how does that affect the patients and the transfer between things?
Oh, I mean, it affects the patient in that we can't tell. I mean, today, our medical records are so terrible or non-existent that we can't rely on that. The diagnosis is locked into the computer from the beginning, and it's always schizophrenia because that's what gets the most reimbursement from the insurance companies. And not being able to talk to other people. Like I had a patient who'd been in this kind of step-down unit for 6 months, and he told me that he was on Haldol or whatever he was on for 6 months, and he just watched TV. And he got out and he immediately got drunk, which actually substance abuse was one of his major issues. Mm-hmm. I don't know if he had schizophrenia at all. I don't think he did, because it didn't feel to me like he did, but he would get very depressed. I think he actually had a traumatic brain injury as a young, in high school. And that changed his behavior, and then things went from bad to worse.
Wow. Okay. Yeah. And if you were able to treat him in the way you wanted, what are some ways you help people in your practice?
With the system that it is, I mean, if the system had worked a little better for him, I would have heard from that step-down unit, and I would have heard that they didn't do any kind of workup. I'd assume that they would have a psychiatrist there who would make sure that the guy really did have schizophrenia, take him off his drugs and see what happened, because it's safe in a hospital. But they wouldn't even talk to me. He signed a release of information, and they just blew me off repeatedly. It was amazing.
Well, and so this is getting into the incentive and money thing. So this is something I found. So the ethics of doctors and therapists is do no harm. And we have a massive ethics book, right? We're supposed to coordinate care. We're supposed to collaborate with other providers. Otherwise, you might be duplicating treatment. You may be doing something. You may be giving them the wrong medication. They may have tried that therapy before and it didn't work. But in most of the system that I'm aware of now, there is not any reimbursement for any sort of collaborative meeting care, except in certain situations when somebody's in foster care. And occasionally then the government will pay for a meeting where you can get all the providers there. Not all of them can bill, though. That's fun. So you have this system where the money is being, it's called fee for service. So every single service you do, you get paid for. Well, not all of them. Like in outpatient therapy, we don't get paid for phone calls, emails, coordination of any sort. We only get paid for the appointments, right? Which is fine in an outpatient therapy setting where people are coming voluntarily and wanting to come and work on it, right? But let's just say you're in a doctor situation that you're in and you're trying to get records from another doctor or call another doctor that's in another hospital that saw this person. They don't have time for you. Where's that time coming from? Secondly, you can't bill for it. So the best you can do is possibly call the front desk staff and ask them to fax over the records. And then you read the records in isolation, and that may or may not help you. Am I hitting that right?
Yeah, definitely.
So the incentives and the ways we're paying are different. So also, some of my mentors told me that back in the 70s, some of the therapy clinics had grants. And with the grant, it was called block funding. And with grant block funding, you could create groups, you could create different things that didn't make money right away. Like groups don't make money right away. It takes a long time to get enough people interested in a community group and like a DBT skills group or a trauma-informed therapy group. But back then it was probably like a talk therapy share group, which can help with socialization. You could help clients access services and different things like that because you had a block funding, and the whole point was just get people better. That was the idea. In the community. But then we became fee for service at some point with almost zero grants, unless you have a very specialized program of some sort of group, such as like maybe the homeless population. You might be able to get a grant for that, right? And so then everything must be billed. And so then clinicians in community mental health are spending upwards of 40 to 50% of their time writing these documents. And the documents aren't even very useful in my experience. I felt like I was just doing something to justify to the government that I saw the person to stop fraud. I'm like, that's not how you stop fraud. Right? I mean, that might be one way, but it's very archaic. I mean, why don't we do this? We have a group of patients. You have 18 months. Okay? That's a year and a half. We want to see their scores on all these metrics go up. We're going to issue them the tests, and then we're going to issue them the test at 6 months, issue them the test at 12 months. We'll issue them the test at 18 months. And then your program gets levels of funding based on that, right? The better you do, the more funding we give you to expand your program. Why is it based on, okay, did they come on Tuesday, September 4th? Okay, yes, you got paid. Oh, they didn't come? Oh, you don't get paid. What? How is that even sustainable for providers? It's a really difficult environment. And community mental health, where people have severe mental illnesses, and they're not always coming. I mean, they're coming voluntarily, but they almost have to have family involvement and doctors and case managers, a lot more helping hands. It's so difficult to coordinate care when the motivations for reimbursement and funding are geared towards the profit-making insurance companies and not helping the providers themselves, who went in and took an oath of trying to, do no harm in all this. We're getting, you kind of have to. I always joke, like, part of my job is a volunteer. Like, I get paid for some things and some things I don't.
Absolutely.
And that's just me volunteering, because otherwise people are screwed. Thoughts?
Right. And even more so with seriously mentally ill people, because you're doing lab work, and then you have to chase down lab results, and you really need to coordinate with other caretakers, with other clinicians, if you can. And you talk to family members, and of course, none of that is billable.
Yes, exactly. And then how important are family members in the treatment of people with severe mental illness? Yeah,
very, very important. Yes. Absolutely. They're the patient's best friend and ally, but the patients don't sometimes really feel like that. But they're our ally, because they can come in and tell us what's going on at home with a patient and what has gone on in the past. And, that's incredibly valuable. We can use it for diagnosis, and we can use it for care and just filling in the blanks.
Exactly. So if parents and siblings and relatives are involved, not only does it help inform the doctor, or the therapist, but it could also help them get more involved in natural community supports. Because the idea in outpatient therapy where I am is we get the person coming in every week. Hopefully they start to make gains with cognitive behavioral therapy, solution-focused therapy, motivational interviewing, EMDR therapy for trauma, right? And then we eventually help them get into safe community natural supports where they can then create friendships and other bonds to help them as they recover. That's the idea.
Yeah.
The hard part is if you don't have any access to any relatives, and you have to get a release of information, but often if people are often people are wanting to help when they're in a bad spot. So they're going to give that information up.
Yeah, right. And I think we can always listen. I mean, if a mother calls and wants to tell me what's going on with her son, I can always listen to that. I'm not revealing anything.
Yes, exactly. That's true. That's true. And so what was the change you saw from your early 70s experience in community mental health to recently being in community mental health? What's the difference that you're what are some of the differences that you're seeing?
So many. Well, because of the IMD exclusion, we have barely any hospital beds. We need so many more than we have. And our county hospital, John George, the Alameda County Hospital, they admit 1 out of 4 people who apply who are on 5150s, which you may know are holds for danger to others or self.
Mm-hmm. Yes.
But only 1 out of 4 of those people gets admitted. And often they will get into the emergency room and maybe get, something. Someone will talk to them, maybe able to get a dose of something. And then as soon as they're not yelling or threatening or they act a little more calmed down, they get sent out on the street. And the family is never called. The friends are never called. They just get just sent out.
And what in the world are people supposed to do when you're on the street? How are you supposed to survive? How are you supposed to get healthier without stability?
Right. So people use drugs, of course. I mean, meth and unfortunately fentanyl to feel better. And because it's hard for them to get to the clinic. I mean, they're confused and they're hungry and they're frightened and I mean, just a place to sleep is difficult.
Yeah,
everything is difficult. Yeah,
and thus go ahead.
Well, aside from prison, you couldn't invent a worse place for people.
Right, and so therefore, people are. And this is another thing, like people that are uneducated about addiction, addiction is a way of adapting to terrible circumstances. No one starts out saying, oh boy, I can't wait to be addicted to cigarettes, heroin, or meth, right?
Right.
They're often doing it to alter their state. And then that eventually becomes addicting because of the way the chemicals work, right? But it's also it's often starting as a way to defend against a terrible circumstance, right? So a lot of people who, it's like chicken or the egg, right? Like a lot of people, if you who are on heroin, when they do interviews of them on the streets, it's like something horrible happened to them. They couldn't get any help. They lost their funding. They lost their job. And then they went on the streets and did heroin. Other people, they tried it. Something bad happened to them when they tried it or whatever. They were going through something personally, and then they started using too many drugs, and then they lost everything and went to the street, And so it's like, there are ways, and there's lots of books on this, which your book is more just about your experience and what you see as we need to fix. But there are plenty of books on what works in treatment. How do we help people get engaged? But all of it takes a more preventative look. And the system is not preventative. It is meant. Our system currently, with the way we do mental health in the United States, is a reactionary system. It's already like when the person's already in the horrible situation, they may get some help, right? Yeah. And that's where we're going with May. Like the hospital beds aren't there. The different ways of treating people long term aren't there. especially for public pay, especially for Medicaid. For private pay, it's like this. Do you have rich family members?
Mm-hmm.
Do you have the best insurance plan that I've ever heard of? Because I've even tried to get people into long-term mental health clinics, okay, with really good insurance, and they get less days, get denied all the time. Who's making these choices? It's the insurance companies. What's their incentive to get people well? I guess less cost, but they're always looking to cut cost and ignoring doctors and therapists' recommendations because they are trying to squeeze their margin because it's for profit, where insurance companies such as Blue Cross Blue Shield was a nonprofit organization when it started. If there was excess money in Blue Cross Blue Shield after the year, they would send it all back to the people that paid in premiums. This is back, I'm talking 100 years ago.
Wow.
If you look it up, Blue Cross was started as a nonprofit, and a lot of insurance companies were started that way. There was a collective. You put in your money, and then if you need it, you pay it out. Mm-hmm. Now it's transformed into something completely different. So that is the hard part, when the ethic of doctors and therapists who are working for ourselves, though we have to be contracted with the insurance companies if we want to be reimbursed in any sort of way, we are trying to uphold ethics and boundaries and best practices. The insurance companies pay people, often, no offense, but here I'm going to go, failed clinicians who can't get a job elsewhere, to gatekeep what we can and can't do based on outdated research, their opinion, cultural bias, and overall to save money. The problem is, in prevention, you have to spend money first to be able to save money. Right. Yeah. So if we do the most care possible on a cancer patient immediately, that's going to save the most money in the long run.
Yes.
It's the same with mental health, but we don't do that. We give people the least treatment first, and we aren't listening to the clinicians. So that's wild. Not even to mention all the reforms that are needed to be in schools and other public places that could help people not need to go to therapy and need to see a psychiatrist as much. Yeah. But that's a whole nother topic. So any thoughts on any of the things that kind of, maybe a story where I want to have you have some positive stories too, where you really help people, but oftentimes their families were involved though. So can you tell me a story that maybe changed your perspective on things in your life?
That changed my perspective.
Yeah.
When I finished training, I went and worked in the county hospital, which was then Highland Hospital. That was the county hospital that took psychiatry patients. And oh my goodness, this was just, it was soon after I finished training. So it was a long time ago. And they were already so short on beds that they would send people out the day after they came in. And we had one patient who actually came in threatening homicide. He had written a letter to his girlfriend saying that he was going to kill her. And he said some very graphic things about what he was going to do with all the pieces that he had of her. He was going to cut her up into pieces, right? So pretty alarming. But, we had lots of people who were just as alarming, and we kept them for 3 days and then sent them out because no beds, right? Mm-hmm. But for him, his girlfriend had a family who had influence, and they came to the hospital and said, "You have to stop this guy. Don't, he's going to kill our daughter." So we ended up having a jury trial because what he needed was beyond 5150 and 5250. He needed long-term care in a psych hospital. And so he had a lawyer, and our side had a lawyer, I guess, and I was testifying actually against him. It was kind of weird. But he ended up going to Napa for, he was certified for 3 months, but he went for maybe 6 weeks or 2 months, and he came out fine. He's, fixed his life, broke up with his girlfriend in the usual way, got back with his band, and so that was in the end a good story, but it all depended on this woman's, her connection.
I see. So in this situation, there was other people involved where you had to kind of do this.
Right. The family, her family.
So, and what are some, if there's people out there, let's go to something positive for a second. If there's people out there who are, wondering, what do I do with a family member who's got severe mental illness? What are some things that you found to be good practices for people?
Well, if the family can be involved, that's really helpful. Bring the patient in.
Mm-hmm.
If we have the time to see people, frequently, we can sometimes make headway with them.
Mm-hmm.
Sometimes they'll try medication after we get, not that they think they're sick, but just because the people that are taking care of them are just pushing them. I had a patient who was brought in by his mother. You might have read him. This is Chris, an early intervention, the story of an early intervention with him. He had schizophrenia. But in the end, he came out really well. But that was after 4 years of work. And his mother and I, between us, we gave him everything that he would have gotten in an early intervention program for schizophrenia. And it was right away. That was the main thing. It was as soon as he got sick.
Okay. And so that led to, basically the early intervention led to the positive outcome.
Oh, yeah. He went off and, he had love and work.
Right. And oftentimes I read something about people in like India having schizophrenia and actually recovering, where in the US, it seems like people with schizophrenia are often like kind of marginalized and put into kind of like outside of society in a way, but not in his case, but just like in general. What's your experience with that? Have you heard of that before?
In India.
Well, in India, what happened is they would give the person a job, give them purpose, and kind of wait it out, and like for them to adjust. It was kind of anecdotal evidence, but like they weren't putting the person away and saying you're screwed up, right? They were saying, here, this person believes something really weird. Let's give them kind of a job and kind of check in on them every day and bring them to a family, keep them in the family. I'm not saying this is like the solution, but they have a different way of the culture is different.
That's a really good point. Giving them a job. The early intervention program is a protocol actually that was researched by NIMH. And the most important thing is how soon you get someone into treatment. It's like within months of the first episode.
Yeah.
But it has 4 parts. And one part is family involvement. And one part is vocal rehab. So to get them back to school or into some kind of work or back to work ASAP, because then they do have a purpose. And then, meds management and long-term psychotherapy. Probably one of the things that you do.
Yeah, we do long-term psychotherapy. And what I would say long-term, I usually mean like a year and a half, because insurance companies also don't like us going over that unless there's like major issues going on. Right. Yeah. And like we should be, and to be fair, if a person is stable in their living situation and they're voluntarily coming to outpatient therapy, usually, if they have major depression or generalized anxiety disorder, or even PTSD to some extent, especially with the new modern interventions, and they're able to do other things besides therapy, they can be back to a good place in a year and a half, even 6 months. The issue is in modern life, people are often moving. There's a lot of financial pressure. There's a lot of stressors in the community. And when there's too many stressors, it does take people longer. And oftentimes other things, major catastrophes can happen. And then they might qualify for another diagnosis or another adjustment disorder or something like that. And so we try to keep it short term, but we do often see that a good year or a year and a half, people really can get back to where they were or better than where they were. Right. And it does take some time because it's a once a week thing. Yeah. And when we see more trouble, we try to bring people into groups, see them hopefully have a group plus individual therapy. If they're really in a bad spot, we got to do the intensive outpatient, which is multiple days of a week of group plus an individual meeting, possibly even partial hospitalization. So we're kind of going up the scale. But the problem is, and I'm going to say this is just even in our world, in the outpatient world, you pretty much have to go into the hospital and say you have an imminent plan to kill yourself at 4 p.m. on Saturday, or they won't take you.
That's right.
They will keep you in the emergency room. They'll give you benzodiazepine, which is a whole other problem.
Right.
And then they'll send you home. And this is not okay. And if they do take you in, I've got a lot of issues with the hospitals that are still existing in the way that they're dealing with things. So I'm not sure how to solve this, because it seems like the system has gotten worse. People have to you have to be very actually almost like functioningly aware to get into a hospital, which is not where most people are when they're in a crisis. They're not in a functioning mode.
No.
I remember I had to, I'll have to change the names on this, but I had to put, this is a patient I had a long time ago, over 10 years ago. And they were reporting that everything was normal. Okay. Mm-hmm. But the police had other ideas because they had picked him up for some behaviors, and his family had other ideas because they had seen these behaviors. Yeah. And it took me writing an entire paper to the county and basically getting a psychiatrist medical director to sign off on this thing hours later. I mean, I was working in a nonprofit, so I think it ate into our grant money, because it certainly wasn't a billable thing I was doing, to get him hospitalized because he was a danger to self and others. And there was police reports saying he had done something that morning that was essentially a suicidal gesture. Wow. And, all sorts of things like that I can't get into detail-wise. And it took me 2.5, 3 hours, because he came in for his therapy appointment after the police incident, after all these things. And it took me hours. I had to, move things around. And then I had to get our psychiatrist to sign off on it. And finally they took him, because he would have never called the police. He thought they were evil. He thought that he would listen to us. But the only way he stayed at our clinic was that one of our clinical managers and him decided to watch YouTube of his favorite music. And that was the only reason he decided to stay there until the crisis team came, because he was so out of it. He was just going to probably walk into traffic or worse again, so we had to kind of almost like soothe him with something, because he could not take care of himself. So the system was, I was very upset at that point. And now I feel like that was 10 or 15 years ago. That's even more difficult to get people hospitalized even now. So I think that's where it's coming into the money, the profit issue, and the way we are doing things as a whole needs to shift, because our understanding of the body, the nervous system, what's needed, the integrative, things we've talked about, like family involvement, community support, are becoming more apparent. What are some of the main issues that I know they're in the book, and I want people to read the book, but like, if people are just like, what are these issues? What are some of the main issues that you would love to solve if it was up to you?
Okay. Well, I have a list of 12 things, but
let's just go for it. Let's give me your top 3, and then we'll go. Let's list the other ones.
Okay. I should have marked this. So, abolish the IMD exclusion first, so we can. And build more hospital beds so we can take people out of jails and put them in hospitals. Have early intervention in psychosis with enough room for everybody, so that anybody with a first break can go right into this intensive treatment program that I just mentioned with the 4 parts. I think students in all psychology and clinical social work should get hands-on training with severe mental illness, because a lot of times that just goes by people and they just wonder why their patient isn't getting better. Requires SAMHSA. I don't know how I say it.
SAMHSA, Substance Abuse and Mental Health Services Administration.
Yes, exactly. So they don't do anything for severe mental illness. They just ignore it. I mean, now they put out something about how they're going to get a referral system going, but that was supposed to entirely be for severe mental illness, not like programs in the high school to help you socialize.
Wow.
and the practice of delegating mental health care to nonprofit organizations. That's really, instead provide the care in one unified system. This is because this is how it was in San Mateo. We had one unified system.
Okay.
Nonprofits may not be bad by themselves, but what happens in my experience is that each one is a little siloed entity, and they compete against each other because there's only so much funding. And when the ones that win seem to be the most politically powerful, or they have the glitziest presentations. That's my experience anyway. Reassess and clarify HIPAA, because it's getting in the way. We need to, allow for, like, if you get in an auto accident and you're unconscious on the freeway, with a head injury, no one would ever make you wake up, wait until you wake up and sign a consent form for treatment. They rush you off to the hospital. But we wait and wait and wait until people get worse and worse. And we don't tell anybody anything. We don't share our information.
Right.
Like in that guy on the freeway with a head injury, they would have radioed ahead. They would have gotten his medical record and see maybe he has diabetes or something else they need to know. We need the same kind of thing.
Yes.
Institute morbidity and mortality review boards in the mental health system. These are, you're familiar with these.
Yes, but can you explain a little bit about that?
Okay. So they have them in hospitals, especially, university-based hospitals. But what they are is a board that reviews cases that turned out exceptionally badly, or badly in a way that shouldn't have happened. So they review situations where things probably weren't handled as well as they could, and they make a determination of what went wrong, and people learn from it. It's not like they fire everybody, but but knowing that is a possibility that your case may be brought up on a review board is certainly an incentivizing thing.
Right.
Permanent supportive housing we need desperately.
Yes. Can you explain what you mean by that?
Sure. We have what we call board and care homes. You probably have the same thing.
Yeah.
People get food and shelter and a bed. But they don't give any kind of mental health care at all. Maybe. Okay. Yeah. And so people get very, very psychotic.
Yes.
I had a patient she was charged with murder because her worst enemy came in the middle of the night from next door with a knife. And my patient grabbed her cane and beat her over the head with a cane, and the one with the knife ended up dead.
Goodness.
Yeah, but this woman with the knife was definitely not properly treated.
No.
And people are just sitting against the wall, staring out into space next to other people. It's just a horrible environment.
Yeah.
So we need something better. Require large private nonprofit healthcare systems to provide acute and subacute inpatient psychiatric care for adults at levels commensurate with community needs. Mm-hmm. And as a condition of maintaining their nonprofit status, and require the same of for-profit hospital healthcare systems as a condition of maintaining their license to operate. I know this is sounds draconian, but use electronic medical records for patient care only and never for billing. 11 is structure treatment teams to encourage collaboration among the team members across disciplines with leadership to foster such collaboration. And finally, create a directory of services up to date and available to every clinician in each public health jurisdiction, like the county in California, so that we can see, open up. If we have a person who's overdosing on fentanyl and has been rescued, but, we'll probably do it again. We could send him. I could have sent him that day. I had a patient like this. I could have sent him that day for immediate treatment. He could have gotten medical treatment. He could have gotten methadone. He could have gotten Suboxone that day. And he really wanted to stop his drug use, but I had no idea where to send him, even though it was just down the street from us. And he overdosed and died.
Oh my gosh.
Later, yeah.
I'm sorry to hear that.
Yeah.
So one of the things I'm noticing is this, because of whatever whatever has happened, the mental health community is disconnected. The public one and the private one are all disconnected.
Right.
And in a way, if we had because our county makes a mental health guide, but it's a PDF. It's not updated daily. There's no integrated technology. There's phone numbers and emails. So good luck, right? It's basically like, it's kind of, again, following another myth, which is, those who are the strongest survive, which is a myth, right? It's actually the most adaptable. But anyway, it's like kind of like we're playing into that myth with our mental health system. Like, okay, lucky you have an advocate calling for this homeless shelter. Right. Other people don't. So the technology in our field is not sharing information. So like, oh, there's a bed open here, there's a bed open there. It's like you have to call and you have to fight for every single thing.
Exactly.
And not only to mention that, then mention reimbursement for physicians and therapists, which is not certain. We are beholden to insurance companies' interpretations and their whimsy, essentially, which is also, what is that doing? It's giving the power to people who have money and capital and don't have almost any healthcare experience. Right. So it's a twisted system. So all of those things could be used to improve. But I really love the one about sharing the information about like a real-time system between hospitals and doctors' offices, and let's say even outpatient therapy. Like, hey, we have every day we could open our portal and say, hey, we've got 15 spots open for outpatient therapy, and then if you're in the system, then everyone could go, oh, well, let's send them there, and versus just randomly calling. Exactly. It's archaic. We're using archaic technology. And I get that some of it is due to privacy laws and that we can't share all the information without patient permission, but we could share availability information and resource in a real-time way instead of a PDF being emailed or something like that.
Right. And it seems like they could change the HIPAA law so that, real-time crisis situation so it can be paused for a real-time crisis urgent situation.
That would be nice. Yeah. So what would you say, what is a way that somebody can get involved who is not a mental health practitioner?
There are a number of advocacy groups. There's one in Washington, D.C., which is sort of the grandfather of these. It was started by Fuller Torrey, E. Fuller Torrey. I don't know if you know his name. Anyway, he's a psychiatrist who he's pretty old. He's probably not going to be with us that long, but he's been working for decades and has a schizophrenic sister. So he's very dedicated. It's called Treatment Advocacy Center, and I think they're in D.C., but they have arms all over the country. The California ambassador, there's California ambassadors, and I'm sure there's ambassadors where you are too. So you can go on their website. It's very, very extensive and very well done. You can also, so that's one. NAMIs, of course. NAMI is a good way to get involved if you have a family member or a good friend.
And so NAMI is a National Alliance of the Mentally Ill, right?
Right.
Is that what that is?
Right.
Okay.
Right. It's mostly mothers.
Right. And so those are some ways to get involved. What about advocacy at the political level? How about people that are really looking for a fight? Maybe they're in a different part of their career and they want to take this up. How do they get involved?
Well, to say that's me.
Yeah, well, possibly you,
that's
right?
What I'm doing.
That's what you're doing right now.
Yeah. There was a group called FASME, Family Family Alliance for Severe Mental Illness, something like that. And they were putting up tents on the streets of Oakland and doing a 3-day demo of sleeping in these tents to demonstrate what their kids were going through. And I read about this in the Chronicle and rushed downtown to find them. And by luck, I found them. And I joined their group, and I've been very active in that group since. So then another one is the National Shattering the Silence Coalition, which is national. It's just, more advocacy. So we have a weekly report of legislative meetings and bills and things like that, and people to talk to. So there's a ton of opportunity for us to advocate. I wish we had better connections. The mayor of Berkeley, the ex-mayor of Berkeley, is very involved, a very good ally for us. And she reviewed my book. She gave me a very nice review, which is published with the book.
That's excellent. Yes. So I would just say it sounds like there are some organizations people can get involved in, but if you don't know what your organization is or you're not sure, I think just starting to get educated about mental health in general, getting educated about community mental health where you live. Is there community mental health centers? How do they function? What are the nonprofits for mental health around? What are the outpatient clinics? Just starting to educate. Get yourself educated, learning about this through podcasts, and then picking a cause. I mean, you named like 12 issues. I named issues with insurances and dealing with that whole thing, which is a whole fiasco. I don't even know how to solve that. My current position as a person who has to bill insurance companies for reimbursement is this. I am going to try to get them what they need to get these people care. So if they need stupid reports that I think are stupid and whatever, and they want me to adjust my diagnosis to say chronic instead of unspecified or whatever they want to make sure that this patient gets therapy, we're going to do what they need because I see it as an ethical issue to get the treatment. I'm not going to fight them from where I'm at. I've got to fight them from a different way, right? And that's through policy change, because me butting up against them as an individual, they're just going to punish me. So policy change is what's needed for insurance companies to have a different incentive and or different policies. And that has been effective in the past. For instance, mental health used to not even be really acknowledged by most private health insurance companies, even just 20 years ago, 25 years ago. So we do have some parity laws in place. But there are many ways the insurance companies are getting around that right now by not providing mental health services or farming it out to some third party or whatever. So I think as an individual, knowing what your rights are in terms of healthcare, which is a very complicated, unfortunately complicated topic in the United States, is a good place to start. And if you've got extra time and advocacy, getting involved in a local group and or something that lobbies on a larger level to the government. I think that both are useful. Obviously, you found something just doing on the ground and having a real impact with people right there where you're at. That's what I'm hearing. You got involved with a local organization.
Yeah.
And or picking something like homelessness. For instance, there was a recent project in Denver where they started giving homeless people $1,000 a month. And by 12 months, 65% of them had jobs and had apartments. I mean, right there. I mean, if you're homeless and you had a catastrophe happen to you, you are probably going to develop a mental illness or an addiction. Right. There's almost no way around it. I mean, just think about what happens in our lives if somebody dies or something tragic happens in your life and you have a house and a job. It's messing you up for weeks emotionally or mentally. So just imagine if you didn't have that security, right? It's hard to imagine. Right. So things like that. I also think just advocating as a local person on your school board to bring in more mental health education to the students proactively, preventatively, relationship education, mental health education, coping skill education, drug education in ways that is smart and useful to students can help be preventative. That's another way of doing it. Being open about your mental health journey. I mean, not in an egotistical, weird way that I sometimes hear on podcasts where people have, I have 7 diagnoses and this, it's like, okay, right. Okay. That's, if you went to a doctor, they would not give you 7 diagnoses. But anyway, in a way that's helpful, that moves the conversation forward, that this is something normal, right? If my finger was smashed last week by something I dropped on, I'm going to go to my PCP. I'm going to go to the emergency room. I'm going to possibly go to a hand specialist, whatever that is. I don't know what the name for that is. I know podiatrist or feet. I have no idea what a hand specialist is. Okay. If I'm having issues with mental health, I'm going to go to a therapist, go to a doctor. I'm going to, make this normalizing. And that's something that can help in our culture, is normalizing that mental health treatment is normal. Mm-hmm. So, I think there's so many ways to get involved. What would you say is your top thing if you could change anything about the mental health care system right now?
I would arrange for early intervention in schizophrenia and also bipolar disorder, but particularly schizophrenia. And I would require and see that it happened for every jurisdiction to have enough early intervention programs that they could handle all the newly, people who are newly on the journey of schizophrenia, who are just having their first break or maybe haven't even had it. So I think we could save so many lives and huge amounts of money, if people care about that, by just treating people early. And I would go around, like you say, lecturing to schools and so on. I would go around to schools and guidance counselors and training programs and to talk about what are the early signs. How do you know that the person you have in your office who's not getting better is actually possibly schizophrenic and needs to be in a program ASAP?
I love that. Very good. I think that is all important. And I mean, in the book, which I've been enjoying, you cover so many of these issues and you tell stories, a lot of stories. So I think for the average reader, you do not have to be in mental health or a doctor or a therapist to understand this book. It's very readable. It's very easy. It's not preachy either. You're just kind of telling your experience and then like, well, here's maybe how this could have panned out differently, or here's some problems I noticed in the system, or this was an issue here. That was kind of what I was getting from that. And I do think, people are, I think oftentimes people in our society are afraid of psychosis and what that is, and schizophrenia in particular. So I think, like anything else, when you get educated about it, it's not as scary. It's scary if it's not helped, if it's not prevented or worked on. Because I know that for schizophrenia, it's so convoluted. We don't really have a cure for that, but we do know that we can have treatments that are effective to help the person live a decently normal life to an extent, whatever that is. Normal for them. Okay.
Well, ideally normal.
Right.
Except that they're in, ongoing medication, treatment, that kind of thing. Follow-up
exactly. Care. So I'm going to recommend the book to everyone. Do you have a website that people could go to?
I do. Yes. It's Alice Feller, MD, all lowercase, all one word.
Okay. .com. Okay.
.com.
Right. Excellent. Okay. And
it's a great website.
Right. And you get your book almost anywhere, it looks like.
Yeah.
So that's good.
Yeah.
And, you do have an advocacy link there as well. Okay.
Right. I have all kinds of links.
Excellent. Yeah. Excellent. So that's a good place for people to go. I'm going to be putting that in the show notes. Right. Is there anything that we maybe something you wanted to say that you didn't get to say yet?
I think that I got to say everything. Thank you. I just wanted to add something to your insurance doesn't pay very well.
Oh, yes. Go for it.
So after my book came out, my husband was, telling everybody about it. And we were on a tour. People came to me and talked to me about it. And one guy said, we don't talk about upcoding anymore. We call it fraud. But then, which it is,
Yeah.
But then he said, but I have another story. And he does this, he's not a doctor, but he does medical analysis for financial situations. People can have him come in and see if their nonprofit is making it or not, and why, how the money's going. So he was hired by a freestanding psychology and psychiatry clinic, and to analyze their money. And it turned out that they were making on their psychotherapy patients, they were making zero. Because people would pay privately, but the insurance companies didn't pay. They discovered that they just didn't have to pay, and people didn't fight it. And so they were working for copay.
Yeah, we have run into that in the clinics where there'll be some technicality and they will withdraw 3 or 4 months, and it's never from an audit or something. It's like from this thing wasn't this plant. So since the Affordable Care Act, it seems like there's like 25,000 different insurance plans under each private insurer. And so they each have their own specification and they're each long contract. Well, as a outpatient provider, I don't want to name insurance names. Let's just say we take a big insurance company.
Yeah.
But all over the country, different employers have put different specs on them, right? And they have these laws that they have to provide certain things. Like supposedly mental health is, you have to provide mental health coverage, right?
Yeah.
Well, it may just be under a big deductible. It may be a copay. And it really depends oftentimes on what plan the employer picked, because a lot of people get their mental health or their health insurance through their job, or unless they're very poor, and then they would get it through Medicaid, right? And or unless they're over 65 and they qualify for Medicare, right? But even then, there's holes in Medicare, as we know. So it's so nuanced that we have gotten plans where we've done a verification of benefits, which means we've looked up their insurance and it says it covers it, and then it doesn't. And so then who's on the hook for that?
Yeah.
Either the provider doesn't get paid, or you have to then go after the client who's already depressed, anxious, God knows what. And now they owe, for 10 visits, could be $1,000 because of the different costs involved. So, or more, this is the issue that I've been noticing, because I've been in business for a while now, as a private practice person, after I was in nonprofits for a while. And I feel like it's almost the same thing the airlines were doing that they've been getting in trouble with, which is just horrible customer service, paying their customer service people nothing, overwhelming them, not giving them the correct answer. So it's almost like intentional negligence. Because if you have intentional negligence and there's no accountability, because if I'm an airline customer, I need to still fly, right? So then I just put up with the fact that I was delayed for several days. I lost $400. They canceled my flight. I put up with this because I have no other alternative.
Right.
And so the new transportation administration is trying to hold airlines accountable for these sort of things and stop all these tricks of what I call inadequate customer service on purpose. So it's not the people that were trained for it. They're just not equipping them. It's the same thing with insurance companies. You call somebody, you get one answer, you call somebody, you get another answer. They don't even know. They have no power to change anything. And you're in this sort of continuous infinite loop of not getting reimbursed. And it's a way to delay payment, obfuscate payment, delay benefits, deny benefits. And it's tricky because on paper, if you held them to the law, if I took a lawyer and I said, hey, excuse me, we need this payment, and I brought my lawyer and paid my lawyer, had my lawyer write a document up for $400. Oh, funny enough, and it fits their policy, it'll get paid. Okay. Yeah. But who has the money to pay their lawyer, to get on the phone, to know their rights? The insurance plans are so convoluted, people often don't know their rights. But we fought in my group practice. We have fought for money. I remember one time a clinician waited 2 years to get payment for a series of appointments, and we kept fighting for it because legally it was ours. Yeah. Legally, the contract said, but they kept coming up with all sorts of dumb reasons not to pay it. I had a recent situation with Medicare where we took the diagnosis and we were
we're very positive it's this diagnosis. It's a very rare diagnosis. And they would not pay it. And the Medicare rep said on the phone, I'm speechless and I don't know why they won't pay this. And it doesn't make any sense to me. But there is the only other thing I can think of is there's other diagnosis that has a kind of a crossover with it. There was another diagnosis that was similar. And so then we researched the chart, look over the whole chart, and realize that technically they could have fit this diagnosis the whole time, which I won't get into well, I can say it was, you have no idea who the patient was or anything, but it was a mood disorder due to known physiological condition.
Okay.
Because this person had all sorts of physical pains that were well documented with multiple diagnoses. And we had tried to diagnose them something more accurate. But this diagnosis was actually less accurate, but it covered it because they were only depressed because of their physical ailments.
Right.
And this is the sort of runaround that no one's getting paid for. My billing person, luckily I have a billing person that we pay on salary here to help all the people get reimbursed. They had to spend hours on it. To then I had to get involved, look at the research, look at the it's a whole thing. So it's getting worse. So I'm not sure what to say, but on the opposite side, oddly enough, mental health is more, quote, accessible than ever because of certain things that have happened. But yet it's sort of a weird game as well when you get into the business of it. It's just not how it should be, because it really ends up really hurting the consumer. Because a lot of people who are doctors and therapists, from not getting paid, they leave the industry. They're tired of it. They're tired of doing what I do, which is like partial volunteering. It's not sustainable. So I think the book is a great that you wrote it, American Madness, Fighting for Patients in a Broken Mental Health Care System. And Dr. Alice Feller, I really appreciate not only your work with patients, but the fact that you're still involved. Are you still working full time? I didn't really understand. Okay, as I thought you were not. But you're still involved, advocacy, talking about this. And as people who may be overwhelmed by the podcast, there's so many issues. Pick one and put your work there. And that, if we all pick one issue, things will change, right? We can't be overwhelmed by the amount of issues with insurance companies. Sorry, I went off on that because it's a pet peeve of mine and I've been dealing with it for years. I don't know how to change that. I think only politics and policies could change that. But really, it comes down to the incentives have to be through, because there's no incentive for them to make it better for people. So it has to come down to the heart of the people who are involved in the business. Do we want to help people or not? What is this really about? So, I appreciate that. Anything else you wanted to mention?
No, I think this has been really fun talking with you. I'm really impressed with your operation.
Oh, thank you.
And how all the work you do to get your patients the help they need. It's really,
thank you.
Really very impressive.
Yes, I appreciate that. And one thing I'll say as a trick is we do a lot of work to get them. But one of the things that we try to do with all the contractors and clinicians and admin that we work with here is that we try to educate them about their health insurance plan and about community support so that they can start advocating for themselves. And not just with mental health, but with physical stuff as well. So that's a huge part of our job. I just want to put that out there, is empowering the clients. And obviously the ones with severe mental illness, that doesn't work, right? We have to help their family, but I'm talking about your average outpatient person. We're trying to educate them, to empower them, to take control, to know what their insurance plan is, to know what natural supports to take advantage of. And that's key as well. But with the severe mental illness folks, unless they got a family, no one's looking out for them. So I appreciate that advocacy on your part. So all right.
Okay.
Well, thank you, Dr. Alice.
Thank you. Thank you for having me.
Take care now.
You too.
Bye now.
Bye.
But I felt the sun on my face when it did come out for that little bloop on Sunday.
And there you have it. This has been another episode of the Intentional Clinician podcast. If you are enjoying the show, please leave us a rating on iTunes or share the show with people you know. I would surely appreciate it. As some of you know, I am passionate about preventing future violence in the United States. I have started a nonprofit with colleagues called the National Violence Prevention Hotline, which is a 501c3 organization. We are endeavoring to gain funding and collaborators and volunteers so that we can start a 24/7 hotline and chat line to reach potential perpetrators before they may act violently. It is a bold effort to curb violence and save innocent lives by working to connect with potential offenders while they are in the planning stages of violence, help to de-escalate them, and provide resources so that they can get appropriate professional help. The National Violence Prevention Hotline is looking to open up a conversation about violence in society, the causes, and the solutions. You can learn more by visiting our website at violencepreventionhotline.org. You can get involved by writing your congressperson from our website, sharing it with your network, or even donating to the cause. If you are looking for an EMDR International Association consultant, I am a consultant and I can help provide 20 hours that you need to become EMDRIA certified. Just check out the show notes and send me a message and see if we're a good fit to work together. If you are in need of counseling, do not hesitate to make an appointment with a local counselor in your area. You can also make an appointment with the excellent clinicians at Health for Life Counseling in Grand Rapids as part of the Trauma Informed Counseling Center of Grand Rapids by visiting www.healthforlifegr.com. And if you are in the state of Michigan, you can also schedule a telehealth appointment. The recording you just listened to consists of the personal opinions of Paul Krauss and his guest, and while these are based upon the literature they have read and the experience in their respective fields, the information on this podcast should not be viewed or thought of as the definitive opinion on any subject. Listening to this podcast is not a substitute for treatment. If you're in a crisis, please call 911 or the National Crisis Line at 988. Support your local bookstore by shopping at bookshop.org. That's www.bookshop.org. It donates a percentage of sales to local bookstores all across the United States, which I think gives character to our cities and a place to hang out and a place to explore. You can order from the comfort of your own home online while supporting businesses near you. If you are a therapist and you are not involved in your local counseling or therapist or social work organization, please get involved to at least pay dues so that we can have lobbyists help keep mental health care accessible at the government level, and also expanding into schools and other places that need it. And also, if you didn't know, counseling organizations and professional organizations are working to keep us from becoming gig workers for a lot of large corporations who are coming in and trying to buy up local counseling agencies or basically pay you what they pay for people to deliver food to your house. So, get involved. Until next time on The Intentional Clinician, I wish you all a safe and peaceful week.